Hi dentists, how are you? This is Muhammad Musa from AFK Study Plan. Today we're gonna start with the articles as we mentioned in the previous video about the introduction of these articles and why they are important and need to be studied. Get your notes, be ready for those. And we're gonna start with the first three articles covering the guideline for management of traumatic dental injuries. First one is speaking about fracture and luxation. Second one is speaking about injury for the primary dentition. And third one is speaking about avulsion of permanent teeth and how to deal with it. Why we are combining the three articles together? Because it's the same idea, but just different tooth and different scenarios. So you should combine it together so it will be easier for you just to compare between them and get one coherent story in your mind, and then you go through it and then you navigate and then you can reach to the answer. These articles are important because these topics is not covered in details in most of the textbook in the NDEB article in NDEB textbook list, and they ask a lot of questions about this one. So please get your notebook, get your pen, be ready. Try your best to answer the questions which will appear in your screen, and feel free to share these videos with other dentists going to the exam. And let's get deep. Okay, first of all, we're gonna start with the primary dentition, as this article is giving you the general guideline and why we need to deal with this stuff, and then we're gonna move on to the permanent teeth for adults. Okay, so he speak about like children aged from 0 to 6 have injury, and that injury to teeth account to 18% of all physical injuries, because these kids try to do like playing football. They call it football, it's soccer but they call it football anyway, and playing hockey, and they come to your office with his parents, his legal guardian, and he's in trauma, he is afraid, he's in pain, and his parent is worried. So what's need to be done? First of all, initial presentation and minimizing anxiety to the children and the parents is extremely important. Why? Because the stressing of both children and the parents is alarming for you. You cannot deal with patient who is anxious and trying to speak with you and he's in rush. No, you need to calm him down. And in this technique, they recommend to use knee to knee examination for young age to use this technique, because like knee to knee, it's like intimate contact between the dentist and the children, so he feel like, okay, I'm in a good hand now. He try to relax and then explain more about what happened, and then you go with a structured approach. It's not like, oh, you have a broken teeth, let's take x-ray. No, first of all, you need to take history, undertaking the clinical examination, collecting test result, and how this information is recorded. Why this is important? If this patient is your patient, so you go to the notes, you know his history, you know if he has cardiac condition, need to take prophylactic antibiotic, if he has allergies to any medication before prescribing it. Why this is important at the beginning? Because sometimes you need to deal, and in the rush of doing the treatment, you sometimes forgot this stuff, and it's not good for the patient and the children and everything. Okay, the initial assessment. So you go for the information you have and you read it carefully, and then you check, and then you go soft tissue injury. You check the lip should be examined for possible embedded tooth fragment, and this is critically important. If you see a fracture in a tooth, which is like big fracture, and the children or the parents cannot tell you, okay, this is a missing part, this is a broken part, or he did swallow it and he didn't pinch anything, and you see a big laceration in soft tissue should be examined carefully. You should palpate it, and even if you need to take x-ray, you can take x-ray to check it. This is very important. Okay, and then you go to test the tooth itself. And for children, it's not recommended to go for cold tests and hot tests, vitalities test. This is not reliable with kids, because like kids cannot tell you, okay, I have pain for 5 seconds, and then he lower his hand. So it's not reliable with children. Not in trauma, in like as a general guideline. This is not reliable for children. Then what you're gonna check? You're gonna check mobility, you're gonna check color, you're gonna check tenderness, the minimum pulse pressure, the position of displacement should be recorded. So you should say, okay, this tooth was intruded, extruded, going labial, going palatal, and this should be recorded, as well as discoloration. Teeth with persistent dark discoloration may remain asymptomatic clinically and radiographically normal. So not every tooth with discoloration you jump to conclusion, okay, this patient need RCT. No, if the discoloration is persisting for a long time, so you should intervene. Here, treatment is not indicated for discolored teeth unless there are clinical or radiographic signs of infection of the root canal system. So if the tooth is discolored, no swelling, no pain, no tender, not tender to percussion, no radiographic change, so you can just let it go. And then you're gonna do the X-ray. So it's like you jumping to X-ray. You should go step by step. And then he mentioned here the use of thyroid collar where the thyroid is in the path of the primary X-ray beam and a lit apron for when parents are holding the child. So from this sentence, I know it's like mind blowing if you think about it, but as it's written here, so you think the thyroid collar is the most important part, and he recommend the lit apron not for the children himself. Like if the parents is going to hold the children, so you should give lit apron to the parents themselves. But like in the article here, and like I know this is tricky for most of our knowledge and practice we do before, we think like the lit apron for the patient taking x-ray is a must, but as mentioned here, the thyroid collar is extremely important, and this is they speaking about it, this is due to their longer life expectancy and the acute radiosensitivity of some developing organs and tissue. You know, like tissue has different sensitivity to radiation. The organ which is developing more has more radiosensitivity than the other organ. Like for example, if we compare bone for young children comparing to enamel for adults, so it's different, totally different sensitivity between them. So here, like if I have a question asking you about which patient has high risk to develop side effect of radiation, and that question giving you kids, so you're gonna pick the kids because of this, because like thyroid is still developing and it's critical and sensitive to X-ray radiation. Okay, comb beam CT following trauma in young children is rarely indicated. You don't need to do this, and as we mentioned, we aim to minimize the X-ray radiation for the children. Okay, and then if the this is critical. So if you feel okay, the children came to the office and then he giving you a story like, okay doctor, like this was broken while I was playing hockey, and the dad said no, this was broken while he was like sitting up, or it was an accident in the school and they called me. If you see the story here is not coherent in the situation where there is a suspicion of abuse, prompt referral for a full physical examination and investigation of incidents should be arranged. So this is the mandate. You are mandated to do this, and this is extremely important. You should be mandated to refer him to a specialist and see, okay, I suspect here abuse pattern, so, and you should report this. You should report this to college, like this child come to my office with his parent and I see a conflict. And then you're gonna say, okay, what if this is not, I was like biased, I thought it's abuse, but it's not abuse. Okay, you are not liable for anything if you report it and it's not a problem, and the authorities did investigation more and it was coherent and no problem in this, you are not liable. But if this child go to other dentists and this other dentist see the pattern and then he reported, you are liable. Again, if he go to other dentists and other dentists suspect abuse here and he reported, they will go to the previous history of this child and say, okay, this kid went to the other dentist, why they didn't report it, and then you are liable in this situation. So again, it's important here because like this reporting stuff is new for us, and you need to take care about this and know when to report and when not to report. Okay, and then he's speaking about the guideline about it, how to deal with it. Okay, so before, for intrusion and avulsion injury are most commonly associated with the development of anomalies in the permanent dentition. Yeah, the previous guideline was saying, okay, if you have intrusion for a primary tooth or permanent tooth, or lateral relaxation, intrusion lateral relaxation, immediate extraction of the traumatized primary tooth if the direction or displacement of tooth is toward the permanent tooth germ. This was before. This action is no longer advised due to the evidence of a spontaneous re-eruption for intruded primary teeth. So again, I think in this page only you have three concepts that need to be clear for you. Extraction of intruded tooth is not anymore. You are mandated to report if you feel abuse for this kid, and the X-ray radiation should be minimized, and the the thyroid collar is the most important part. Okay, and then the management strategy. First thing first, observation is often the most appropriate option for this primary teeth trauma, unless there is a risk of aspiration, ingestion, or interference with the occlusion. So if you feel the tooth is like mobile and interfering with the occlusion, then you should interfere. Otherwise, you just watch it. Okay, so let's go with scenarios. Okay, so again, as I mentioned before, it's a scenario and then you are building up. He speak about enamel fracture, enamel dentin bulb, and then intrusion, blah, blah, blah. So it's one scenario and adding more. So I will, just to save your time, I highlighted the important part that you need to know in every slide. So story start here and adding up. So if the fracture involve only enamel, no radiograph is recommended. Smooth any sharp edge. Parent education about it, like exercise care when you eat, it will be status sensitive. You don't need to intervene in any way. And then you explain to the parent favorable outcome, unfavorable outcome. So the parent should follow up his child. Like if it's normal color remaining in the crown, no sign of pulp necrosis, continuing through development, he's happy, everything is good. But if the crown discoloration appear, if there's sinus tract, if there's persistent dark gray discoloration or radiographic signs of pulp necrosis, or no further root development is happening for this tooth, so he should come back to the office and then speak with you. Okay, there's a story and we're gonna build over it. Okay, so what if the fracture including enamel and dentin? Here you see this mentioned clearly. The location of missing tooth fragment should be explored during the trauma history and examination, especially when the accident was not witnessed by an adult or there was a loss of consciousness. So if the question giving you a scenario about a children or a parent saying, okay, I didn't see my child while he was playing and he came to me and the other children told me like he was knocked out, he was unconscious for 10-15 minutes, then it's alarming for you. So why he was knocked out for 10-15 minutes? And you see that the child is sitting in your chair, he's good, he's alert for you. No, this is alarming for you. You should refer him to medical emergency so they can check more. Especially if the tooth is missing, you cannot see it. You should first of all check the soft tissue. If you find it in soft tissue, it's amazing. If you cannot find it, you should refer him. They will check chest x-ray to explore where is the broken tooth, where is the avulsed tooth. Okay, x-ray should be covered. Cover all exposed dentin with glass hammer or composite, and then lost tooth structure should be restored using composite. So you cover it with glass hammer first and then you cover it with composite. Glass hammer is like gentle on dentin, and then you build it up with composite for aesthetics consideration for sure. Clinical examination after 6 week radiographic follow-up, and then you tell the parent the same story about the favorable outcome or unfavorable outcome. Okay, so let's go to the third step. If the fracture including enamel, dentin, and the bulb is exposed, again, location of the missing tooth segment should be explored, even if you need to take soft tissue x-ray for the lip, and then you take x-ray for sensor size 0 for young or size 2 for maybe 9 years old. And then you should aim to preserve the bulb vitality. This is the main goal of this treatment. Preserve the bulb by partial pulpotomy. Local anesthesia will be required. A non-sitting calcium hydroxide paste should be applied over the bulb and cover this with a glass hammer cement and then a composite resin. So what this mean? This mean like we are aiming to preserve the bulb vitality. As long as the tooth has no necrosis, there is no, like BDL support is good, so we should aim for partial pulpotomy. So what's the difference between partial pulpotomy and complete pulpotomy? Partial pulpotomy is more conservative. You just removing soft tissue inside the coronal board, maybe 3 mm, 4 mm until the bleeding is stopped, and then you apply non-static calcium hydroxide paste, and then you apply glass hammer, and then you build the tooth with a composite. Okay, this rationale, why we should use this rationale, because we need this tooth to be vital to keep it in place and make sure to keep space for the permanent tooth. Okay, but the evidence for using pulpotomy is indicated for teeth with large pulp exposure. So cervical or like complete pulpotomy, if your exposure is big, if the C exposure is not like small, if you are removing soft tissue inside the coronal bulb, you remove 3 millimeter, 4 millimeter, and still bleeding. Okay, so you should do complete pulpotomy for this tooth. Okay, for sure, treatment depends on the child maturity and ability to tolerate procedures. Some children after the trauma he feel like, no, I want to go home now, I want to rest, so you can book him back. That's why we said before, you should distress the child, distress the patient, and speak up with his parents, give parents education, and then follow up 1 week, 6 to 8 weeks, 1 year radiographic examination, and you give the same story for the parents about the favorable outcome or unfavorable outcome. Okay, then we gotta speak about the fracture that extend beneath the gum line. So the child come to you and you see a fracture here, and this is part is mobile. This part is mobile. So you have two scenarios: either the fracture including the bulb or not including the bulb. So what to do now? First of all, you need to take X-ray to see the extent of the fracture, and most important, to check if there's a fracture in the labial plate of bone. Sometimes the fracture is happening here, and you can see this clearly. There's a step here, so you should take X-ray to take a baseline, and then to check the fracture extension. Where did it go? Okay. Usually, no treatment will be the most appropriate option in the emergency situation, but only when there is a potential for rapid referral within several days to a child-oriented team. So again, child-oriented team is a critical point here to be keep it in mind. If treatment is considered at the emergency appointment, local anesthesia will be required. Remove the loose fragment and determine if the crown can be restored. So this loose fragment can be removed. You just remove it and then look at the tooth after you remove this one. If restorable and no bulb exposure, cover the exposed dentin with glass hammer. If restorable and the bulb is exposed, perform pulpotomy. As we said before, partial pulpotomy or complete pulpotomy. If unrestorable, after you remove the broken part, you see the tooth is loose, the remaining part is too small, then you should extract all loose fragments, taking care not to damage the permanent successor tooth and leave any firm root fragment in situ, or extract the entire tooth. So it depends on the situation. If the child is too apprehensive, you cannot deal with him, you extract the part that you can extract and you book him back to do the full extraction. But if he's good and he is like calm now and you can deal with him and you decide to take it out, take everything. You do not leave anything inside. Treatment depends on the child maturity again, and then you should give instruction for the parents and then give him the favorable outcome, unfavorable outcome. This is extremely important for the parents to be aware what's going on with his child. And then if you have a fracture in the root itself, so depend on the location. As long as the fracture is going deep in bone, so it has favorable prognosis. Why is that? Like, think about it. If the fracture line is away near the apex, so this part will be relatively stable. But if the fracture line is here, it will be not stable. So as we mentioned before, we extract the broken part. X-ray should be done. And then if the coronal part is not displaced, no treatment is required. If the coronal fragment is displaced and not excessively mobile, leave the coronal fragment to spontaneously reposition, even if there is some occlusal interference. So occlusal interference here is not a key factor. So, okay, I should remove it now or I should do some stuff now. No, as mentioned here, if the coronal fragment is displaced and is not excessively mobile, leave the coronal fragment to spontaneously reposition even if there is some occlusal interference. But if the coronal fragment is displaced, excessively mobile, and interfering with occlusion, two options you have now. First option, extract only the loose coronal fragment. The apical fragment should be left in place to be resorbed. So you think, okay, so let's remove this part, leave this part. Why you leave this part? Leave this part as a guide for permanent tooth, so it know its way and it keeps the space for the permanent tooth. Second option, gently reposition the loose coronal fragment. If the fragment is unstable in the new position, then stabilize the fragment with a flexible splint, attach it to the adjacent uninjured tooth, leave the splint for 4 weeks. Okay? And again, that treatment is depend on the child maturity. So in this scenario, the new part here, you aim for no treatment unless there is severe interference, and you should intervene, and the part is broken, is extremely mobile, and then you should follow up 1 week, 6 to 8 weeks, 1 year, and then corona fragment has been repositioned and splinted. He come back to you after 4 weeks to remove the splint and check the situation of the tooth now. Favorable outcome, unfavorable outcome. Okay, as you can see now, it's a pattern, just adding more. But like when you have the question, you should know the story, so to add more over it. Okay. And then the last part, or the last scenario, if you have alveolar fracture, as we mentioned before, and this can be seen easily when the clinical inspection. You see the labial board has like a step, and then it has a fracture involving the labial plate of bone. X-ray should be taken. So use size 0 sensor or size 2 sensor. Lateral radiograph may be indicated here. Fracture line may be located at any level, so you should check which level is it. First of all, reposition under local anesthetic solution for sure, and displace fracture. So you should displace it again, replace it again, which is mobile and or causing occlusal interference. Second, you stabilize with a flexible splint to adjacent uninjured teeth for 4 weeks, and treatment should be performed under a child-oriented team, and the story goes on and on. He come back to you after 4 weeks to remove the splint, and then check the situation of the bone, how it happened, and the mobility of the teeth. And it's not like if the child come to you after 4 weeks and the tooth is still mobile, you don't move the splint here. So splint here is done to give convenience for the child that the tooth is not mobile, because the tooth, if the tooth is mobile, the child usually try to play with it, play with his tongue, play with his finger, and there is a risk that he would aspire it. So it's extremely important to do the splint for the convenience of the child, and also to give the tooth a chance to heal again. The children have amazing capacity of healing. Okay. And then this is done with the first part. So the second part speak about the other fracture or other consequence after trauma. Maybe it has a concussion. Concussion, the tooth is tender but not mobile. You do nothing. No X-ray needed. Nothing is needed here. But if the tooth is tender and mobile, you have increased mobility, not like mobility grade 2, but like increased mobility. X-ray should be taken. You might suspect a fracture here in any way. If there is only subluxation, and by the way, concussion and subluxation in X-ray, you will see nothing. It's nothing. You cannot determine, okay, this is concussion or subluxation from X-ray. It cannot be seen in X-ray. No treatment is needed, observation only, and follow up after 1 week, 6 to 8 weeks. You should tell the parents about favorable outcome and unfavorable outcome. And then here we go with the new guideline. Yeah, this one. So extrusive luxation. Okay, so the tooth might go out. The child is telling you, I feel the tooth is longer now or coming out. Displacement of the tooth out of the socket. First of all, you should take X-ray. In this X-ray, you can see radiolucent line between the tooth and the alveolar bone inside it, meaning the tooth is going outside. Treatment decisions are based on degree of displacement, mobility, interference, and the ability of the child to tolerate emergency. If the tooth is not interfering with the occlusion, let the tooth spontaneously reposition itself. But if the tooth is excessively mobile or extruded 3 mm or more than 3 mm, extract under local anesthetic solution. So again, the new guideline here, before we should just take it out immediately. No, if it's not mobile, it will be mobile for sure, but not extremely mobile, not extruded more than 3 mm, so you can leave it and it will be spontaneously reposition again, and follow up 1 week, 6 to 8 weeks, 1 year, favorable outcome, unfavorable outcome. Here, there is one more point here. Continued root development in immature teeth is part of favorable outcome. Before we didn't mention this, now we should mention this. So if it's an immature permanent tooth and you see the root is open, so you should leave it. This tooth has a huge capacity of healing. It might reposition again and everything will be fine. Okay? The next scenario, if this is a new scenario we speak about in the beginning of the article, lateral relaxation. Before we use to say if lateral relaxation like this picture is going to interfere the Eruption of permanent tooth, immediately extract. Now, no. You just take X-ray to cover your baseline. You have X-ray for documentation and to know the extension of the fracture, how it happened. If there is minimal or no occlusal interference, the tooth should be allowed to spontaneously reposition itself. A spontaneous reposition usually occur within 6 months, up to 6 months. So you don't need to worry about it. You just leave it. It will reposition again by itself. Okay, so in situation severe displacement, two options available. Option one, extraction when there is a risk of ingestion or aspiration of the tooth. As I said before, so you should wait. Like if the tooth is mobile and you feel that child is not cooperative, he might play with this tooth, so you extract it and get rid of it. But if you feel like the child is cooperative and the parents can deal with him, so gently reposition the tooth. If unstable and it's a new position, splint for 4 weeks using flexible splint attached to the adjacent uninjured teeth. And there is a new guideline here, like before we used to use rigid splint, now not anymore. We use flexible splint, max we're gonna use semi-rigid splint. Why? Because the micro movement of the tooth while it is splinting, or it is splinted, give her more capacity to be healed. If you make rigid splinting, the tooth will not even have any movement. It will have micro movement. This micro movement is not good for healing. When the tooth has some movement ability, some movement space, this induce a PDL and the healing process to be like faster or efficient more. This is a new guideline about the splinting, and we're gonna speak about this at the end of the articles. And then we're gonna speak about the next scenario, intrusive luxation, and this is also a new guideline. So before, if we have intrusive luxation for primary tooth or immature permanent tooth, we should extract it. Now we don't do this. We go for X-ray. Apex is located toward the labial or palatal. We don't care about this one. The tooth should be allowed to spontaneously reposition itself, irrespective of the direction of the displacement. Spontaneous improvement in the position of intruded tooth usually occur within 6 months. In some cases, it may take up to 1 year, so you don't need to worry about it, as long as you have favorable outcome. So if the question is speaking about your left hand, and it came after 6 months, and you take more X-ray, and you see the root arrested development, no further root development, and closed, negative impact on developing tooth, so you should intervene now. But if it's not, you should just leave it and don't deal with it. It will reposition again by itself, okay? And then last is avulsion. If the tooth is completely out of its socket, so first of all, location of the missing tooth should be explored if the parent has a tooth, so you need to deal with it, and this different topic when I speak about it. Or if it's not, so you should explore it for soft tissue laceration. If you cannot see it at all, you should refer him to a medical emergency. X-ray should be taken here to check if there's more fracture here or a missing part is a broken part still inside the socket. And there is a very important guideline here. Avulsed primary teeth should not be reimplanted. And we're gonna speak about it later. I think you can figure it out now why we shouldn't reimplant avulsed primary teeth. Okay, and then follow up 6 to 8 weeks, and then we're gonna discuss about the avulsion in a separate article because this is a huge topic and it has more guideline to be covered. Okay, the main point here, the primary tooth is not to be reimplanted again. Okay, summary of all this article is speaking about child maturity and ability to cope with emergency situation is the primary factor. You're saying, okay, I'm gonna deal with him, or gonna refer him to other maybe pediatric office to deal with him. Use of analgesics such as ibuprofen and acetaminophen is recommended because pain is anticipated for sure. And then he's speaking about this avulsion should not be reimplanted again, and you can see answer here. An avulsed primary tooth should not be reimplanted. Reasons include a significant treatment burden, including reimplantation, splint placement and removal, root canal treatment for a younger child, as well as the potential of causing further damage of the permanent tooth or its eruption. However, the most important reason is to avoid a medical emergency resulting from aspiration of a tooth. So, to explain it more, the clinical outcome of reimplantation is ankylosis. When you do reimplantation again, the best result you're gonna have is ankylosing. So think about it, like if the primary tooth, you're gonna bring it back inside the child mouth to be ankylosed. So for sure you have permanent tooth coming from labial side, from buccal side, so you're giving him problem. And as the article mentioned, honestly, this is a weird point, but like as it's saying here, the most important reason to avoid medical emergency resulting from aspiration of the tooth. So usually they're saying that child tend to play with the tooth and is not very careful about it. So he might, while he's sleeping, tooth is falling out and then he aspire it and it will be a big problem. Okay. Antibiotic is recommended only for avulsion. We're going to speak about it later in the other articles. And I think that's it for this article. Prognosis and the training skill for the team is very important. I hope that was beneficial for you, covering the main concept here. Feel free to rewatch the video again, leave me a comment, leave me your feedback, and that's it. See you later.